This is an 81-year-old gentleman, presents to his physician with cough, hemoptysis, fatigue, requiring increasing rest during the course of the day. Past medical history is reasonably unremarkable. History of hypercholesterolemia, controlled on statin, hypertension, well controlled on a calcium channel blocker, mild arthritis. So this gentleman has no history of smoking. He's quite active. He continues to play golf several times a week. He drives. He's fully independent, maintains all his normal activities of daily living. Chest X-ray and CT show a cystic mass in the left upper lobe, as well as lymphadenopathy in the left hilum and both mediastinal nodes. PET-CT confirms these findings, shows fairly marked uptake, FDG uptake in the lung mass and in lymph nodes. Bronchoscopy and transbronchial lung biopsy are performed, and path confirms grade 3 squamous cell carcinoma of the lung. Genetic testing in light of his never smoking history is performed, and this is completely negative with no evidence of an oncogenic driver. PD-L1 testing by IHC shows expression in 65% of cells. The individual is started on treatment with pembrolizumab, with follow-up imaging at 3 months showing stable disease. After about 5 months on immunotherapy, unfortunately, the patient is hospitalized with a seizure. At the same time, he reports increasing fatigue and cough over the preceding month. CT confirms enlargement of the primary mass in the left upper lobe. Brain MRI confirms multiple small intracranial metastases. He is started on whole brain radiation, and immunotherapy is discontinued. The patient is actually started on a 2-drug chemotherapy combination, carboplatin and nab-paclitaxel, or nanoparticle albumin-bound paclitaxel. So this gentleman presents with locally advanced squamous cell carcinoma of the lung. Technically, this individual has stage 3B disease. Bilateral mediastinal nodes would confirm N3 disease. The primary tumor presumably is at least a T1 or T2. Historically, we would usually treat such an individual with concurrent chemoradiation. Platinum-based regimen, either weekly Pac-carbo or etoposide cisplatin, combined with 6 to 7 weeks of full dose RT, a minimum dose of 60 gray. And we can see cure rates in selected individuals approaching 20–25% in that cohort. Now, there are some individuals, for one reason or another, are not appropriate for radiation. The field may be too large, or there may be additional nuances in a case such as this, where there may be satellite lesions or contralateral intrapulmonary metastasis that make full-dose curative chemoradiation inappropriate. If we assume that to be the case here, then the choice of treatment, pembrolizumab, based on the level of PD-L1 expression, is quite reasonable, and certainly would be my first choice, assuming we had ruled out a curative approach with chemoradiation. At this point, PD-L1 testing, I think, is standard. But clearly in metastatic or stage 4 disease, or in individuals who have recurrent disease, we can debate whether it should be standard or not in stage 3 or stage 3B non-small cell. But an individual with non-curable disease who has expression levels of 50% or higher is well served by frontline checkpoint blockade by immune modulator, in this case pembrolizumab, which has clearly shown a survival advantage compared to standard chemotherapy in this setting. Now, it's intriguing. This gentleman has squamous cell carcinoma, which almost always, but not always, is associated with the smoking history, and yet he was a never smoker. Had he been a heavy smoker, male with squamous cell, I'm not so sure I would have ordered molecular testing. Next generation sequencing takes 2, 3, 4 weeks minimum to turn around. We would end up delaying our intervention based on this waiting period, and the likelihood of actually harboring a mutation in the setting of a smoker probably be less than 1 to 2%. But in a never smoker, regardless of histology, I think it is reasonable to obtain mutation testing or molecular testing and look for actionable molecular aberrations. I would guesstimate the rate of mutations in that group in never smokers, even with squamous cell, would be on the order of about 10 to 15%. So perfectly reasonable option.